Okay, we have case number 6 with CHF and COPD, and her name is Mary Rosa. This is by Alyssa, Evan, Matt, and myself. And our patient is a 67-year-old female with 3 sons. She complained of unusual fatigue and found herself sleeping most of the day. Her oldest son found her sleeping in the afternoon and thought she was disoriented. So he took her to a physician who found edema in her bilateral lower extremities and recommended hospitalization. There she was diagnosed with pneumonia, dehydration, chronic heart failure, and COPD. She underwent a 3-day stay at the hospital and was discharged to a skilled nursing facility. Her medical history: she has a history of degenerative joint disease, especially in her knees and knuckles. She also had a bout of pneumonia last year and was subsequently diagnosed with CHF and COPD. She lives in a 2-story home with a half bath on the first floor. There's only approximately 12 stairs from her front door to the street. She is unable to undergo community ambulation to buy groceries. She needs assistance for yard and house maintenance. She is still able to clean her laundry and cook food independently, although she is unable to reach the overhead shelves in the kitchen and closet pole when putting the clothes away. She used to be a 5th grade teacher but is now retired, and she currently enjoys listening to the radio and visiting with her family. Okay, with the ICF model, her body structure and function: she is A&O times 3 with mild confusion upon walking and in the afternoon. She complains of pain at end range, especially in her fingers, shoulders, and knees. She is 4 out of 10 at rest and 7 out of 10 during activity. She has decreased dynamic sitting and standing balance. She also has poor endurance and requires minimum assist and minimal cueing with bed mobility, except she requires moderate assist with supine to seated positions. Patient utilizes half bed rails at home. She requires minimum assist with minimum cueing with all transfers. She only utilizes wheelchair mobility for long distances and also requires max assist. She has decreased cervical, bilateral upper extremities, bilateral lower extremities except for the shoulder and ankles and toes, range of motion. She has decreased strength in her cervical, trunk, and upper and lower extremities. Activities that she's able to still undergo: she's able to communicate, and she's also able to self-feed with frequent dropping of the utensils. She's able to perform grooming activities at a slower rate, but has to use her bilateral upper extremities. Some of her limitations: she requires moderate assist with bathing with her upper body and max assist when bathing her lower body. She is unable to shower, secondary to fatigue and lack of endurance. She requires to be seated with armrests to dress and requires moderate assist for upper body and max assist for donning garments and dressing her lower body. Seated to standing requires moderate assist after dressing. And toileting transfers requires moderate assist in the afternoon and if she has a bowel movement. Assistance varies on time of day and also fatigue. Participation includes cooking and laundry, and she is able to use stairs once in the morning and in the evening. She is restricted when it comes to grocery shopping, house and yard maintenance, and she is unable to garden. She cannot reach overhead on the kitchen cabinets and closet poles. She is also unable to use the stairs frequently, so she has to stay on the first floor. She is unable to community ambulate, and she cannot drive. Her internal environmental factors: something positive: she's anxious to return to normal activity with the support of her family because she wants to gain her independence back. Something negative, she will miss gardening, which may lead to depression and sadness, and her lack of independence with bed mobility, transferring, toileting, and bathing may lead to her feeling overwhelmed. Some external environmental factors, she has 3 sons who will help her with grocery shopping, traveling to appointments, and house and yard maintenance. Negative, she has approximately 12 stairs from her front door to the street, hindering her from leaving her house independently. She's also not married, so she doesn't have someone to help out at all hours of the day.
Alright, our goals are to be completed in 3 weeks. The first one is patient will be able to independently transfer on and off the toilet 2 complete times in 5 minutes, allowing rest breaks in between to allow independence during transfers at home. The next one is patient will be able to will be independent in bed mobility, including rolling, bridging, and scooting 5 times each to allow her to reposition herself in bed. Patient will require minimum assist for verbal cues, for hand placement on bed rails, to transfer supine to sit 5 times to allow her to get up and out of bed in the night if she needs to go to the bathroom. Patient will be independent with a sit to stand transfer, reaching full knee extension during 5 out of 8 trials to allow her to get out of the chair at home. She will increase in all bilateral strength measurements to a 4 out of 5 to increase independence in the home, mobility, and self-care. She will ambulate 100 plus feet with a standard cane with verbal guidance given for sequencing, encouragement, and proper gait pattern. And lastly, she will be independent in her home exercise program to be able to maintain and progress her to home status, or in her health status as she returns to home.
Okay, then our intervention is just based on the goals we came up with. Some were from her, working with her. So during the treatment, we're going to encourage the use of her inspiratory spirometer, that hopefully she's getting some respiratory therapy, and work on diaphragmatic breathing and pursed lip breathing. Well, just during the exercises and when she's taking breaks. If there's a lot of fluid, we can incorporate positioning to help with the drainage and allow gravity to assist. And then for bed mobility training, we're going to work on bridging, rolling, and scooting. When needed, we'll offer minimal assist to begin and then progress to her doing them independently. For bridging, we can offer the physical assist to help lift her butt in the air, and then we'd progress letting her do it on her own. She can further progress this to performing a bridge by using only one leg, so we do that on both legs. And then to help with scooting, we do the bridge, but we'd have her feet placed over to the side, and then she can pick her butt up and move it, followed by moving her trunk and shoulders over to get in a line. And we can help again with the trunk if she needs it, but then the main goal is to have her do it on her own. For rolling, we're going to encourage her to use the grab bar on the side of the bed to assist with her upper extremities, and we could encourage bending her top leg to help move over to assist with the rolling. For her supine to sit transfer, we're going to begin with the head of the bed raised up, so she doesn't have as far to sit up, so she can still have an achievable goal to make. And then to progress, we're going to slowly move it down all the way, so she's completely supine, and then we can have verbal guidance, so she's activating her core and use her handrail if she needs them. For her sit to stand transfer, we're going to work on transferring from a higher hard surface at first, such as a table, and then progress to a lower softer surface such as the bed, so then it's something that she can be motivated with because she's actually going to complete the transfer but still make the progression lower and a softer surface to make it more functional. For strength, we just want to increase her overall strength, so her lower extremity strength is going to be improved from her transfers and walking that she's doing. We could also work on mini squats, touching her butt to the bed or a chair, some TheraBands, strengthening all the joints and all the muscles around the joints and all planes. Then upper extremities, we could use some light weights and TheraBands, trying to maintain or improve her strength.
Okay, so right now I'm just going to briefly go over some of the age-related changes that occur in the pulmonary system. Beginning with, you have an overall decreased mobility of the thorax, and this is due to a variety of different reasons, such as the stiffening of the joints, the calcification of the cartilage, and muscle wasting. You also have structural changes of the lung tissue. Also, this would include changing of the size and diameter of the airways, the alveoli. You have increased production of fibrosis, which leads to the framework of the ducts and the air walls changing. Additionally, these changes will then lead to increased resistance and airflow and a decreased ability of the thorax to move. All in all, this leads to air having a more difficult time moving in and out within the lungs. And for our patients, this means they are unable to tolerate activity as they were able to before. For additional information, I refer you back to the pulmonary systems and aging lecture that we went over earlier this semester. Just a couple definitions. We're going to go over obstructive conditions and restrictive conditions. Obstructive conditions can be thought of any condition which affects the lumen size and disrupts the internal airflow. Common examples: COPD, asthma, emphysema. Whereas restrictive conditions will be those conditions which affect the structural changes of the thorax themselves, which limit the ability of the thorax to expand. So any postural abnormalities such as scoliosis or kyphosis. All right. So again, our case number 6, we had a patient with COPD and congestive heart failure. So as we talked about just the previous slide, COPD is an obstructive disorder which limits the internal airflow of the lungs. Commonly, you may see a patient with COPD present with excessive use of accessory muscles. They may have an anxious look on their face because they're not able to get the proper amount of air in and out of their lungs. This is important because you need to be aware of hypoxic shock, cyanosis, if they're looking blue or pale in the face, and really use your dyspnea rating scales. That's important when you're evaluating your patients. The main focus here is you should focus on strategies which compensate for the changes that have already occurred in a patient with COPD. You're not really going to be able to restore the structural and tissue changes. So compensatory mechanisms such as pursed lip breathing, energy conservation techniques, strengthening of the respiratory muscles will work very well in patients. Also, additionally, you can talk with the physician about possible oxygen supplementation if that's needed for the patient.
Alright, this is the first of our article reviews. This one's on 6-minute walk work for assessment of functional capacity in patients with COPD. The purpose of the study were to examine the 6-minute walk test distance and multiply it by body weight and use that product as an improved outcome measure. The researchers found that the distance multiplied by the body weight could be used as an improved outcome measure for the 6-minute walk test. Some positives from the external validity: there's a lot of participants, 124 men and women with moderate to severe COPD. There's a wide age group from 45 to 81. Some negatives of the study: the majority of the participants were men, and the researchers excluded individuals that had comorbidities such as cardiac, renal, or endocrine diseases, individuals with cardiac arrhythmia, on exercise testing, and so on. Some internal validity, some positives for that: they use different tests to obtain all sorts of data. They looked at pulmonary functioning, exercise, gas exchange, ramp cycle, and the 6-minute walk test, of course. Another positive, they took in consideration the differences between the men and women, meaning that the men they weighed more, they were taller, and they have more functional ability compared to women. A negative for it. The 6-minute walk test was performed in a hospital hallway. They didn't really describe how the hallway was set up, so there could have been distractions in the hallway, employees, other patients, so the consistency between patients may not have been what the researchers wanted. Clinical use, the 6-minute work could be used as a good measure for reporting exercise capacity with individuals with COPD, and a future study, they should involve patients with comorbidities such as the ones that the researchers excluded for the study.
Okay, the next article review was on, it evaluated the use of pedometers for monitoring walking activity as an outcome assessment for pulmonary rehab. They found that a standard pedometer worn at the waist did not detect lower extremity activity following pulmonary rehab due to lack of sensitivity, although they did find improvements in the dyspnea scores, exercise tolerance, and quality of life measures. Some positive things about the external validity is that it used a specific sample size that had to meet the criteria of being referred to pulmonary rehab, clinically diagnosed with COPD, an FEV1 over FVC less than 0.7, and able to perform a 6-minute walk test, and did not have any other comorbid conditions that would interfere with completion of pulmonary rehab or walk testing. It also allowed subjects who required ambulatory oxygen to participate. One of the negatives about the external validity is that it only used subjects ages 61 to 77, and it did not include an assessment for upper extremity strength, even though it was included as part of the pulmonary rehab. Some positive things about the internal validity: it used criteria to assess the pedometer's accuracy prior to the start of the study, and only used patients whose pedometers were within 20% of the observer-counted steps. They also used 3 different clinic locations in Rhode Island, Connecticut, and New York that all abided by the same guidelines, and all used standard outcome measures like the 6-minute walk test, the MRC dyspnea scale, and chronic respiratory disease questionnaire. Each pedometer was placed in the same location around the waist and in the same location of the belt. Some negative things: trust was given to the patients to wear the pedometers during all walking activities, but it was shown that the pedometer was only used approximately 50% of the time. Patients with a slower than average walking speed experienced less sensitivity with their pedometers compared to average walking speeds. Patients were told not to look at the activity monitors on the pedometers, but it cannot be determined if the patients really followed through. And only those with low baseline scores had significant improvements in the study, as it may just be a result of exercise conditioning that increased exercise tolerance. We can use pedometers for clinical use as a feedback tool to increase compliance in those that have low exercise tolerance with COPD. When patients can see how many steps per day they are taking, it may act as a motivator to keep walking more and more each day.
The article I reviewed was on a drug called NBA237, which was a bronchodilator, and overall the study was measuring if the effects of the drug on exercise tolerance with patients with moderate to severe COPD. They did this against a placebo group. To administer the drug, they used it through an inhaler, and it was a double-blind study, randomized trial, and a crossover design. So it was a 3-week trial, and the results of the study showed that the daily treatment of the bronchodilator demonstrated improvements in exercise tolerance and endurance in patients with moderate to severe COPD. It also resulted in the reduction of lung hyperinflation at rest, improvements in resting inspiratory capacity, residual volume, and functional residual capacity. For that exercise, they did some cycling. They monitored it every day and took measurements every 3 days, and they saw immediate results even from the first day that they were given the drug. So for internal validity, they use the same spirometry equipment for all assessments performed by the patient during the study, and they were calibrated for each study visit. All investigators who were doing the study received detailed training on the exercise endurance test methodology. At the initial visits, practices were ran to make sure they knew what they were doing, conducted for the pulmonary function and exercise test to ensure that the site staff was familiar and competent in the test, and they had a limited number of staff members to actually perform them. Men and women with severe to moderate COPD were included in the study, and they had to be 40 years or older. They had to have a smoking history of at least a 10-pack per year, and then their FEV should have been less than 80, greater than 80, or less than equal to 40% of the predicted normal, and FEV1 over FVC less than 70%, and it was measured at the initial appointment. They were not eligible for the study if they had a lower respiratory tract infection in the past 6 weeks, if they required oxygen, had other pulmonary diseases, had a history of asthma, history of malignancy within the past 5 years. They could have some basal cell carcinoma. If they had hyperplasia, bladder and neck obstruction, moderate to severe renal impairments, urinary retention, narrow angle glaucoma, or history of the alpha-1 antitrypsin deficiency. They were also excluded if they had experienced adverse reactions to inhaled anticoagulant agents, if they couldn't use the inhaler. For clinical use, the treatment could be used to lead to improvements in exercise tolerance and endurance with patients to moderate to severe COPD. So this could benefit patients that don't have the endurance to perform the exercises activities you want them to do in therapy, to help improve their functional ability and return them to home. So for future research, I just kind of did what I would like to see, and I would want a larger sample size because I had about 100, there's about 90 some. I'd want a more specific age range because it was just 40 years or older, and then some more follow-up data on advantages and disadvantages if they kept doing it, or if they discontinued using the drug, if they would have any benefits from that.
Alright, so the article that I chose to review was looking at the effects of pursed lip breathing and how that would affect the signs and symptoms of dyspnea on patients with COPD. So just a quick overview. I think we all know what pursed lip breathing is. You can use this type of breathing in many types of pulmonary conditions that we've already talked about in patient care. The exact mechanisms are not 100% sure, but we're going to kind of go over a few of them, which the authors pointed out in my article, which may lead to the benefits of pursed lip breathing. Alright, so the study had 14 patients, 10 of which were males, 4 females. They ranged from moderate to severe COPD. The purpose of this study, as I mentioned, was just to see the effect of pursed lip breathing on exercise capacity. Before the study was began, respiratory rate, maximum inspiratory pressures, max expiratory pressures were measured before performing a 6-minute walk test as a baseline. During the study, participants were randomly selected to either use their normal breathing pattern or the pursed lip breathing pattern after they completed a additional trial of the 6-minute walk test. Measurements of the same variables were then determined and compared. Alright, and then inclusion criteria is listed. So you need to have stable COPD, no recent exacerbations, and then COPD was diagnosed based on the clinical findings such as pulmonary function tests, x-rays, and actual examinations by the researchers. Exclusion criteria included any type of exacerbation. If you were an active smoker or you had comorbidities such as diabetes, hypertension, tuberculosis, and respiratory illness. Alright, the researchers used a randomized crossover study. I've listed the dependent and independent variables, and the weaknesses of the study were the small sample size. Again, as I said, only 14 total participants. And then also the authors noted that they took into consideration the changing of pressures in the lungs, they did not look at the influence of pursed lip breathing on the diaphragm. The study's findings. So overall, they found that pursed lip breathing did improve exercise activity for the patients. This was seen in decreased reports of pain with breathing. They had decreased hyperinflation of the lungs after they used pursed lip breathing, and they were also able to get more air in and out following exercise and return to a more normal, slow, deep breathing pattern following the 6-minute walk test. Reasons for these results. Okay, so it is hypothesized that pursed lip breathing caused slower, controlled breathing pattern, which prevents the hyperventilation, which is often seen with patients with COPD and other pulmonary conditions following exercise. The reduction in hyperventilation then allows for a more complete expiration, so less air is being trapped in the lungs. You have an increase in tidal volume, which means more the gas exchange is better, is improved. Alright, why this is important for us as PTs? Because pursed lip breathing is a simple, easy technique to use and to treat. It will improve the tolerance for activity for your patients, and because they are able to tolerate more activity, we'll be able to get them out of the hospital or wherever we may be treating them quicker, get them back to leading a more independent life, which is a win for everybody. Alright, so here's just some clinical pearls to wrap everything up together. Some quick overview. There they are for your use. So use them whenever you need. You guys want to say anything?
No. There's the references if you want to look up our articles.